Assalamu alaikum, everyone, and thank you, Novartis, and thank you very much for the introduction. I will actually won't take too long, but I will go take you through a small journey. Hypertension is something I see a lot. About 80% of our patients with diabetes that we see, unfortunately, have hypertension. And therefore, I call it, this is kind of a forgotten enemy in a way. Enemy in the sense that, it kills. And we take it for granted that, we know how to do it. But to be honest, we don't do it very well, let's put it this way. Despite the fact that we have a number of medications, and now the guidelines are pretty much saying the same thing across different societies. But anyway, hypertension, as you all know, large majority of it, 90 to 95%, is essential. We really don't know. There are several reasons for that. But basically, it is idiopathic in a way how it all happens. The secondary hypertension happens in a very small cohort of people, and a lot of them I see in the clinic as an endocrinologist, and some of my nephrology colleagues, what they do. Pre-hypertension or elevated blood pressure, I think it's an important and interesting entity. Interesting in the sense that it still exists. But in a high-risk situation, there is no such thing as elevated blood pressure. So this category, which is elevated, this needs to be treated when you're dealing with a high-risk population. What has happened in hypertension more recently is that the Chinese studies that have come in quite recently in the last 6 months or so, they have shown that if you reduce the blood pressure to below 120/80, you still have a lot of benefit in terms of mortality and morbidity. So the normality now is defined as less than 120/80. So that's quite an important message to take home, that blood pressure which is elevated more than 120/80 in high-risk individuals should be treated. And we'll take you through some of those. The problem is that, there are several factors. I just share with you, I chair the quality of the institution, which is Imperial College Diabetes Center in Abu Dhabi. So we look after about 34,000 diabetic patients. We were achieving 80% control of hypertension. But since we've reduced the number, our percentage of control has dropped to 58%. And a large majority of that is related to because we as physicians don't do the right things. So hypertension, if you look at the guidelines, is very clear. In high-risk populations, you start with combination therapies. In 1 or 3 months, if you don't achieve the target, you move on to triple therapy. And if you still don't achieve, you look at a few other things, okay? It's as simple as that. But it's our inertia, I think, which is coming as a big factor why we are not controlling this condition. So out of all these factors that are contributing, and I may ask the question, how many of your patients in practice are actually controlled? Do you actually look at it? Do you actually, take a note that hypertension is a risk factor? We are mad about cholesterol and other things, but we overlook hypertension. So I think it's a good reminder coming to all of you who see a lot more hypertension than me. I'll take you back a little bit for those who want to refresh themselves. I do all the time as to what is blood pressure, because if we don't understand the physiology and pathophysiology, we really don't understand how these medications will work. So the first section, a few slides, is all about, what is blood pressure. So it's basically systolic blood pressure is the pressure in the aorta when the heart is pumping blood. This is as simple as I can make it. And the diastolic pressure is the pressure in the arteries when the heart is being filled up, right? Pretty straightforward. So if the blood pressure goes low, the kidneys produce a substance called renin, which then starts a cascade of events, angiotensin, and that is converted to angiotensin 1 and later to angiotensin 2. And this angiotensin 2, when it acts on the receptor, it does a lot of things. It constricts the vessels to build up the blood pressure. It releases aldosterone, and it increases sympathetic activity. Okay, so far, simple physiology. Now, this is the most important component, which is the renal component. And I want everyone to understand the pressure-natriuresis relationship. You may be managing hypertension for a long time, but to be honest, this is a very simple, cool concept. If you understand this, you will know a lot of things make sense then. So what it is that the amount of salt you eat, your kidney has to excrete that salt to make sure the balance of blood pressure is maintained. So if you eat too much salt, the kidney has to build up a lot of blood pressure so that it can filter out a lot of sodium, okay? This is why we restrict sodium. The natriuresis is basically sodium excretion. That's what the word means. Now, what I see in diabetes, a lot of the hypertension that we see is salt sensitive, right? So keep this in mind. The pressure and the salt excretion are really, really the key to how the blood pressure really works. This is again in a cartoon form, what I just described about how renin starts the cascade of events, and that leads to, angiotensin 2, and therefore, the effects of angiotensin 2. Now, ACE inhibitors do something better in the sense that ACE also stops the breakdown of bradykinin, which is a vasodilator. But unfortunately, vasodilator, it is very good for the blood pressure and everything else because it releases nitric oxide, but it also causes cough, and this is the reason for ACE inhibitors cough. The ARBs, on the other hand, do not have this side effect, but the studies of both ACE and ARBs now show that their blood pressure lowering is probably equal. Okay, so ACE inhibitors, which have been in practice for the last kind of 30 to 40 years now, and we had enough experience with that. But anyway, just taking you through that the pressure-natriuresis relationship, the renin-angiotensin-aldosterone system, and how ACE and ARBs work. Again, the same thing that if you don't block this, there is a lot of bad effects that happen, which is right at the bottom. Now, does it actually translate into outcomes? Of course, yes. This is basically a pooled analysis of mortality and morbidity, right? It's not efficacy about lowering of blood pressure. But if you treat with these medicines, does it save life? Does it make less people die? Yes, it does. And what is interesting here is that in this pooled data, which has quite a lot of landmark studies, if you can see, the renal and IDNT and all those trials, the blood pressure was 150/90. So imagine if we now lower it to 130/80 or maybe 120/80, this benefit will be a lot more, right? So treating blood pressure with these medications saves life. Less people die. Now, the second mechanism is neural. Now, neural mechanism is because in patients with hypertension, they have a higher sympathetic drive. And therefore, what sympathetic drive does, I think we all know, it will cause vasoconstriction, it will make the heart pump more blood, and obviously reduce the venous capacitance, and therefore also lead to reduced sodium excretion. The aim is you're preparing for fight, fright, or flight. So neural mechanism is another mechanism, very important, because when I talk about the drugs, you'll understand why we are using the drugs for hypertension that we are using. So calcium blockers, two types. One is the L cells and one is the T cells. So if you can see here that the medication which act on the T channel, which is in the heart, are diltiazem, verapamil, or amlodipine. And basically, these are good vasodilators. They relax the smooth muscles. Beta blockers obviously counteract the sympathetic drive. Alpha blockers, again, cause vasodilation. They disrupt adrenergic activity. And diuretics basically make you pee out more sodium and therefore shift the natriuresis curve to the left, and therefore, you have less renin, less aldosterone. So far, it makes sense. And then I introduce you to a new thing. This is the new area, which is the endothelin system. Now, endothelin is so I showed earlier nitric oxide, a peptide which dilates. Endothelin, on the other hand, does the opposite. So from the endothelium, as it says, it basically makes the vessel constrict. And when we showed, if I showed you the definition, the diastolic pressure was related to pressure in the vessels, really. And so endothelin has a key role to reduce peripheral resistance. And endothelin works through two receptors, and now we have a blocker which is FDA approved for this, but it is usually used in resistant hypertension. So an important area, endothelin receptor blockers. This is coming into the market soon as well, but not for general use. So today's last section is about today's talk, and I think our chair introduced about Entresto, which we all kind of know from the heart failure treatment, as we mentioned. But one of the things that I have just shown, and I use the word natriuresis, which is like sodium excretion. And, one of the best things that this drug does is, address that side of things very effectively. And it is a combination. So you get the angiotensin receptor blocker, and then you have this whole natriuretic effect through the natriuretic peptides. So if we look at the atrial natriuretic peptide, ANP, you can see that it is expressed in the atria. I think we knew it for a long time. But the effects are very interesting, and a lot of the effects of these peptides are vasodilation, which is relaxation of the vessels. And one of the things it does is that when the atria or the ventricle is stretched, these peptides are released, and they affect then the target organs. In the kidneys, for instance, it will make the kidneys excrete more sodium, so a diuretic effect in a way, and therefore the effect on stretch on the heart is reduced. Okay, so 3 peptides. I know that we use NT-proBNP as a marker in heart failure. We do in diabetics as well, because almost 60% of our diabetics, unfortunately, have kind of, what we call heart failure with preserved ejection fraction. They have diastolic dysfunction. So we just finished the ADOPT study, and it will be published soon as well in terms of, what it does to diabetics. So just to take you through what this natriuretic peptide does is that if you look at, it has receptors on the target organs, and what it offers there at the level of the heart is cardioprotection, at the level of kidney is renal protection, and then obviously at the level of the blood vessels as well. So neprilysin, again, is an enzyme which breaks down these peptides, the atrial and ventricular or the vascular peptides coming from the heart and vessels. But at the same time, it also breaks down angiotensin 1 and 2. So if you block it, angiotensin 1 and 2 will go up. And this is why we combine it with an angiotensin receptor blocker. Okay, so otherwise, if you just use this blockade, it will result in high angiotensin 1 and 2, if it makes sense here. And if angiotensin 1 and 2 is high, you can see the biological actions at the bottom, which really are pretty bad. So it is very important that, we combine this medication with an angiotensin receptor blocker. So if we do that, the effects are very good. They are complementary. So you can see that, if we block neprilysin and at the same time we block the angiotensin 2 with valsartan, we get beneficial effects, which again, on the natriuretic peptide system, you get vasodilation. But on the other hand, you reverse the sympathetic effects and also the effect of the renin-angiotensin-aldosterone system, which are essentially vasoconstrictive and blood pressure elevating. So the combination makes perfect sense, that you have a combination which reduces the activation of the renin-angiotensin-aldosterone system, but at the same time will make you pee out more sodium. Okay, so this is the effect that they were using in heart failure. But what was realized, that it's a very good blood pressure drug as well, and now it is licensed, as we just heard. So let's look at the evidence, a few slides in terms of, does it really work? Has it been compared? So yes, so it has been, this is Japanese study with systolic hypertension. Very simple study, over 1,000 patients. But the primary endpoint was, does it reduce systolic, kind of mean systolic blood pressure from baseline compared to olmesartan, and it compared two doses. And what you can see here is that the blood pressure effect, particularly on the systolic blood pressure, is very marked. If you look at the gray, which is olmesartan, and this is standard dose is like 20 milligram versus standard dose of like 200 milligram of Entresto. So it's pretty good effect on the systolic blood pressure, but the secondary endpoints were looking at diastolic blood pressure as well, and mean systolic pulse pressure, which again is has a beneficial effect as well, which was both statistically significant. Side effect-wise, not really bad. I mean, quite comparable, no extra side effects from the medication. So pretty well tolerated in this study. But the good thing was that the effect over 24 hours was very good, and whether you dip or you don't dip, because the drug effect is quite sustained. So the drug reduces systolic and diastolic blood pressure with a sustained effect. Now, looking at, again, cardiovascular remodeling, because it's a heart failure drug in the end. So does it actually protect the heart, right? This is the other thing one wants to know. So this is basically a protective study, again, double-blind and active control. The primary objective here was on cardiovascular remodeling, right, in patients with essential hypertension. Again, not a big number, but, 114 patients. And if you look at it, the distension effect or distensibility changes were not terribly different, but the effect on blood pressure, both central and LV mass, was very protective. So the drug, in addition to lowering blood pressure, had an effect on the LV mass as well. So hypertension, we all know, will lead to left ventricular hypertrophy in the end. So we have a drug, if we use early, perhaps offer a protective role. Again, in my patients, or let's say the patient that I see with diabetes, we have an extra effect. We get more people on control. If you can look at 74% versus 54% on olmesartan. So we get more people on target, and as chair of the quality for the institution, this was quite music for me that we have a medication where, at least with compared to, olmesartan has much better effect. But this was interesting that it also has a beneficial effect on the glucose. This is HbA1c, a very short-term data, but what is very interesting is that neprilysin inhibition may raise the GLP-1 levels, and this is why you may have a beneficial effect in diabetes. So quite interesting, early kind of indications. Again, it improves left ventricular hypertrophy compared to olmesartan. No surprise, because as we said, we are looking at ventricular stretch, use in heart failure and all that, and this was quite expected. So again, let's look at against another angiotensin II blocker, which is valsartan. So this is again a study which was looking at this is an efficacy study in lots of ways, in excess of 1,300 patients compared with valsartan, dose for dose, different doses, starting dose and higher doses as well. And if you look at it here, across it, it shows that, the Entresto combination compared to the lower and higher doses was more kind of efficacious in terms of lowering of systolic and diastolic blood pressure and pulse pressure. Again, the secondary outcomes were again similar: diastolic blood pressure and 24-hour mean pulse pressure. So all of these and 24-hour systolic blood pressures, we've seen significant improvement. So the drug works compared with at least two blockers that I have shown, olmesartan and valsartan. Now, this is very interesting because this drug increases eGFR, and therefore the beneficial effect on kidneys were also looked at. And if you look at it here, the effect on the creatinine is protective, and the effect on the GFR is more protective as well. And interestingly, there is less proteinuria in people who were using Entresto, primarily because of the improvements in eGFR and blood pressure control. So I think I will stop here And if there are any questions or anything else, we'll take it from there.